Okay, let's start up again. So we're continuing our discussion of gram-positive pyogenic cocci. We've covered staph now, and for the rest of this afternoon, we're going to cover two genera. We're going to talk about streptococci and enterococci. Now, up to a couple of years ago, this lecture was just on streptococci. It was not enterococci, and the reason for that is because the enterococcus uh, genus did not exist. So it was relatively recently. What happened is that a number of species that were in the streptococci, it was decided that they would be moved out and put into a separate genus, which was called the enterococci. And obviously, the reason they were together in the first place is because they had so much in common with one another. So they're very similar species, as you'll see, and are very similar. The genuses are very similar, and they cause very similar diseases, but they have been split. So now there's only one species within the enterococci which we need to discuss, and we are going to be discussing today. So I think we're covering 6 species, 5 of which are streptococci, and 1 of which is enterococci. So as I say, that's why it's we're talk about the 2. It's just really just for historical reasons, but let's say for historical reasons, the species which we're going to talk about today have always been discussed collectively, and it's still useful to do that. I'm not going to have a separate lecture just on the enterococci, which is to say I'm not going to have a whole lecture on the one species, which actually causes a very limited amount of disease. All right, there's your content objectives for the material I'm going to talk about for the next hour or so. Common properties of, as I said, we're going to talk about 5 or 6 species. What do they all have in common? They're all gram-positive cocci. In fact, everything we're talking about today are gram-positive cocci. These are pairs or chains. So remember the staph, which we already talked about. If you grow staph, they form grape-like clusters. These typically form these chains. With one exception, staph pneumoniae, which will be the last one we discuss this afternoon, actually forms these very distinctive diplococci. But what you don't see is the grapes. Again, part of your normal flora. We talked a lot. Many of these strains you'll find in the nasopharynx, in the skin. But I'll also give you examples of ones that are additionally found in the gastrointestinal and the genitourinary tract. And the reason we're going to talk about them is because that's actually where they can cause disease. And we already talked about Staph aureus that can actually cause disease. It's sometimes found in the genitourinary tract where it can cause disease. So they're not limited to the nasopharynx and the skin. It's just they're more commonly found in the nasopharynx and the skin. They are catalase negative, remember, so that does distinguish them from staph. So staph was catalase positive. These can't make catalase, but somewhat paradoxically, they are facultative anaerobes. So even though they don't make catalase, they can grow in the presence or absence of oxygen for mechanistic reasons, which I'm not going to go into today. It's not important if you understand. It just represents there are redundancies within the respiratory pathways within these species, that I say, that allows them to grow in the presence of oxygen, even though they lack a catalase. So, and they are fastidious, which means that they have they're picky when it comes to what they eat or what they grow upon. That's what fastidious means. I mentioned blood agar plates back in the first lecture when we talked about Staph aureus and how Staph aureus can actually cause beta hemolysis, because it makes these hemolysins when you grow it on blood agar plate. The important difference here is that Staph aureus, you don't have to grow it on a blood agar plate. You can just grow it. They're not fastidious. You can actually just grow them on a normal agar plate if you like. The species that we're talking about now, you have to grow them on blood agar plates. They won't grow on normal agar. So here's the 6 species we're going to talk about. We'll talk mainly about pyogenes because, like aureus, it's responsible for a lot of different diseases. Probably the best known disease is strep throat. But as you'll see, it can cause skin infections as well. A lot to talk about with pyogenes. We'll talk a little bit about Streptococcus agalactiae. It's not, it's also very important. It's associated with meningitis, neonatal sepsis. I'll give everybody fair warning. There's something odd going on right now with my PowerPoint presentation. I think it's a PowerPoint issue rather than a connectivity issue. But if it turns out to be a connectivity issue, I'll connect right back on and we'll pick up again. So I'm just giving you some warning here, but I might have to exit the presentation in a minute and re-enter. I might have to close out my PowerPoint. Agalactiae, I say neonatal sepsis, meningitis, very important, but we're only going to talk about it briefly. The reason for that is we do have a lecture in the next section on bacteria of the central nervous system, so it'll come up again. Streptococcus bovis, there's another one that causes endocarditis. Enterococcus facialis, that's the one enterococcal species. Again, endocarditis also can cause urinary tract infections. We'll talk about that a little bit. Pneumoniae, very important. We'll spend a fair amount of time on that. But again, it's going to come up again. We do have a lecture on respiratory infections. So pneumoniae will come up again. It also causes meningitis, so it'll come up again in terms of that. And mutans, which there's endocarditis again. And this is an interesting infection. You find it in your mouth, but it's not the back of your throat, right? It's where you'll find it is on your tongue and in your gums, and it's responsible for dental caries, which is another term for cavities. So we'll talk a little bit about that as well. Yeah, I'm afraid. All right, looks like my PowerPoint is frozen. So I am just going to pause recording. All right, so I've resumed the recording. We'll pick off where I left off, and hopefully we won't have any more issues. But if we do the same thing happens again, I'm just going to keep doing this over and over again, and we'll keep going as far as we can. All right. So again, with this theme, we're talking about distinguishing. Now, it's not just a matter of distinguishing between 2 staph species. What we have here is 6 different species that cause very similar diseases. And so now we have to have tests available to us to distinguish between these 6 different species. So there's going to be a series of tests you need to be familiar with already here, all right, to distinguish between the streptococcal species. The first test, and I'm showing you here, is hemolysis. And again, it's growth on blood agar. So I told you that these all have to grow on blood agar. So that's what a blood agar plate looks like. It's either they're red, it's because they've got sheep's blood in them. And some of these strains, and if you were to grow Staph aureus on a plate like this, it would show beta hemolysis, which is what I'm showing you here. And I'll describe it for you in a second here. So what happens, okay, so that's what Staph aureus does, but strep strains can do that as well. And they can do that in different ways, and it can look quite different. And so, there's something that's called beta hemolysis, there's something that's called alpha hemolysis, and there's some strains which can't undergo hemolysis at all, and we refer to that as gamma hemolysis. So this is what beta hemolysis looks like, and this is what Staph aureus does, but it's also what Pyogenes and Agalactiae do. So here's our plate, and we're growing, and if you see those little red dots in the middle, that's the actual colonies. And remember that what these strains are doing is they produce hemolysins, and those hemolysins are then spreading out and lysing the red blood cells. So you can get that nice clear halo around that central colony. And when you get that clear halo, that's referred to as beta hemolysis. Pyogenes does it and Agalactiae does it, but the other 4 strains don't, all right? So that allows you to separate those 2 from these 4. Now it can also look like this. This, again, think of that little white dot as being the colony in the middle. Now, instead of being a clear zone, what we have is a green mucousy area around it. This is a partial hemolysis. So the red blood cells are partially hemolyzed. The heme is still intact. That's why you get that green sort of color. That's the color of heme. It's green. So you get this kind of a green color. We refer to that as alpha. Pneumoniae and mutans, that's what they look like when they grow. Now, bovis and physalis, they're both kind of wimpy. So sometimes they won't show any hemolysis at all, but if they do show some hemolysis, they may show alpha. So the utility, the usefulness of this test is really for these 2 here, Pyogenes and Agalactiae. You say beta hemolysis, that usually you can say it's one of those 2. If you see alpha hemolysis, that's not particularly helpful. I mean, it tells you it's not one of these 2, but it really only narrows it down to 4. So we're going to be talking about other tests that help us distinguish between these 4. All right. And those of you who are worried about recognizing this on an exam or something, on an exam I would not show you a plate like this or a plate like this. I would simply tell you that it's the organism was beta hemolytic or alpha hemolytic or no hemolysis. So you need to be familiar with this chart, but I'm not going to show you images. I'm not going to put images like this on the exam. All right. So that's one way we can distinguish between some of these, but we're not there yet, right? How do we distinguish now between Pyogenes and Agalactiae? Because they're both beta hemolytic. So we have to have additional tests. So here's another very useful test, and this is called the Lansfield group test. So this was named after a person. So Lansfield is a woman. She was a microbiologist, and she spent her whole career studying streptococcal species. And she was very interested in their cell walls. And streptococcal species have carbohydrates in their cell walls, and they're very specific for the different species. So different species can have very different carbohydrates. And so what she did is she made antibodies. She made antibodies that specifically recognized these different carbohydrates that would allow her to distinguish between these different species. So she had what she called, group A Streptococcus, which Pyogenes falls into, and they have the A carbohydrates and they react with the A antibody. Agalactiae has B carbohydrates and it reacts with the B antibody. All right. Bovis and physalis both have the same, and they have what she called the D carbohydrates, and she made antibodies that just recognize. So that antibody doesn't distinguish between them, but it certainly means they're not A, B, or pneumonia or mutant. And she wasn't able to generate specific antibodies for pneumonia and mutans. So where these groups are really useful, obviously, is right at the top here. So, if you're beta hemolytic, if you're Streptococcus beta hemolytic, your Pyogenes or Agalactiae, and then you do your Lansfield group test. If it's group A, that tells you it's Pyogenes. If it's group B, it's Agalactiae. So that's again, a common useful test. And there's other tests as well. So you never, in microbiology, you never depend on one test. You always do, you always have backup tests, confirmatory tests. So here's another 2 different tests that can be used to distinguish between Pyogenes and Agalactiae. The first used to be a fabulous test. It was called a bacitracin test. Bacitracin, obviously that's an antibiotic, and pyogenes is sensitive to bacitracin, and A. galactii is resistant. So, the resistance, that's, you can just, you'd plate these out on plates that had bacitracin into them, and in the plates, and if they didn't grow, then it was pyogenes, and if it did grow, that it was A. galactii, and that was very cheap. It was overnight. It was a wonderful test. But we don't use it too much anymore. And the reason we don't use it too much anymore is because what we're seeing is more and more pyogenes strains developing bacitracin resistance. And so as we get more resistant strains, that test became less and less in favor, and it's less useful. But you do see it showing up on exams, and you're not necessarily examining this course, but it might show up on an examining course. But these, bacitracin resistance still shows up on board exams and dental school exams and things like that. So it's worthwhile knowing about that test. This is a better test. This is the PYR test. That's what PYR stands for. Don't memorize that, but know PYR, P-Y-R, this test. It's not an antibiotic test, but it's an aminopeptidase. Pyogenes makes it, A. galactii doesn't, and you can test for the presence of that peptidase. So pyogenes is PYR positive, A. galactii is PYR negative, and that's again, that's an automated test. That's really becoming, probably one of the more useful tests for confirming whether you have a pyogenes infection or an A. galactii infection. So know your tests. All right, so let's talk about those two first. So let's start with pyogenase. We're going to spend a bit of time on it. So it's group A, remember? So the Landsfield, according to the Landsfield group, it has group A, carbohydrates on its surface. We know it's beta hemolytic. So it's sometimes just referred to as a group A beta hemolytic streptococcus or GABHS, or sometimes it's just called GAS for short. So if you hear GAS, some bacteria, a clinician will refer to it as a GAS infection. They're talking about group A streptococcus, or in which case they're talking about pyogenes. Part of your normal flora, nasopharynx, skin, about 5 to 20% of any given population have these on their nasopharynx or on their skin. It's highly infectious. It can actually invade intact skin or mucous membrane, which is quite remarkable. And by that, I mean, there's been a number of documented cases of skin infections where there was no evidence, it was not possible to detect on that person's skin whether there was any break in the skin. It seemed to have infected right through the intact skin. So that's, for infectious agents, that's a very unusual property. Because of that, you can have a very low inoculum. You can have very little of it on your skin, but it can still get in under certain circumstances. And like Staph aureus, it causes a lot of different diseases. Let's look at its virulence factors. So we talked about different kinds of virulence factors. We covered some of them for Staph aureus. Let's look at some of the more interesting and important ones now for pyogenes. Pyogenes has a surface protein called the M protein. Okay, so that's probably one of the more important proteins that it expresses on the surface. Here it is here. Notice it's anchored in the cell membrane, passes through the cell wall, and then has this long sort of helical repeating, highly conserved structure on the outside. And then it ends up in this very, very variable region. So this is what we call the variable region here. This molecule is thought to support infection by pyogenes by being antiphagocytic. So it prevents the bacteria from being engulfed by macrophages and neutrophils. We used to know exactly the mechanism by which that happened, but it turns out we were wrong for many, many years, and now we have no idea how it protects the bacteria. So it's sort of, again, another one of those back to the drawing board kind of issues. So we don't know how an M protein is antiphagocytic, we just know that it is. Now, even though it's antiphagocytic, I would argue that this is actually the Achilles heel. This molecule is the Achilles heel of this bacteria. And the reason for this is it's highly immunogenetic. So it elicits immune response. So you will generate antibodies. You'll generate a lot of antibodies to this variable region at the end, and to a lesser extent, antibodies to this more constant region here. And you'll generate those antibodies, and those will enable you to clear the infection. Unfortunately, they won't provide immunity. So you won't be, they don't prevent you from being infected again. And the reason is because this area is so variable. It's now estimated that there are 20 different versions of this N-terminus here, or this terminal region. So 20 different pyogeny strains with 20 different regions. So even though you raise a wonderful antibody response to the strain you're infected with, you may never see the strain again. The next strain you infected with may have a completely different terminus. So your antibodies are not infected, so you get disease again. You can get infected over and over again with pyogenies. It's estimated that most people get 5 or 6 pyogenies infections, some kind of disease, usually some kind of respiratory issue associated with, 5 or 6 infections by the time you're 20. Now, after you're 20, they're less rare, because by that time you've seen so many different variants of this thing that you have this whole repertoire of antibodies that are, to a greater and lesser extent effective against it. But, very uncommon. There's big cases of children getting, 2 pyogenies, different pyogenies infections in the same season. And that's the problem with this variable region. There is an immune response. You will raise antibodies to this constant response, much lower level, but those antibodies actually are quite problematic. And we're going to talk about those antibodies a little later in the hour. All right. So that's the M protein. This, it also makes streptolysins. So we talked about, and there's 2, we call S and O, and these, so it secretes these streptolysins. Remember what they do is they, as the name implies, lysins, so they lyse cells. These particular ones, they do lyse, red blood cells. We know they can lyse red blood cells because they're beta hemolytic, right? But they also lyse polymorphonuclear cells. In other words, that's another word for white blood cells. So again, neutrophils and macrophages can be lysed by these, and that helps in the infection. IgA-A's is something that they secrete that destroys a secretory IgA. So these are immunoglobulin A. It's a type of antibody that we find that's found in your mucus. All right, so it's very uncommon to find immunoglobulin IgA circulating in our body or circulating in our blood, where most of the antibodies are found. However, we have probably more IgA than any other antibody at all, but you don't find it in circulation. Where you find it is in our mucus. They're secreted into our mucus, and their function is to destroy things like bacteria and viruses that come into our mucus that have to pass through the mucus in order to infect. So you'll find these, for example, in your nasopharyngeal passage within the mucus, you'll find a lot of these IgA antibodies. And the bacteria has to get past them in order to get to the mucosal cells and to actually infect. And so to accomplish this, the bacteria produces this IgA-A. So it secretes this within the mucus, and this will actually destroy those secretory antibodies, allow the bacteria to adhere to the cells. So again, it's a virulence factor. C5a peptidase, again, it's not an immunology course. If you don't know what complement is, don't worry about it. It's part of our immune system. It's one branch, one arm of our immune system. And what the C5a peptidase does is it actually cleaves C5a, which is a complement protein which is attached to cells. and causes those cells, and you can opsonize a cell with C5a, and it will cause that cell to be engulfed by neurophages, macrophages. And again, if you get rid of C5a, you're actually getting rid of the whole complement pathway. And so you can't, and that's a pathway that we normally use to fight bacterial infections. Here's some more virulence factors associated with pyogenes: hyaluronidase, streptokinase, DNase. Hyaluronidase can hydrolyze connective tissue, so it degrades connective tissue. So bacteria, once it infects, it doesn't go into cells. A pyogenes is an extracellular bacteria, so it's sitting in connective tissue. It needs to move through that connective tissue to divide, so it needs to be able to degrade it. So it uses hyaluronidase to do that. Streptokinase dissolves fibrin clots. So what happens is, if you get a bacterial infection, part of your antibacterial response will be all the vasculature, all the blood vessels around that point of infection. You'll recruit platelets to those blood factors. You'll recruit platelets, and you'll plug all of those. You'll form those clots in all those blood vessels. The idea is, so if the bacteria gets into the blood, it can't then spread throughout the body because you've blocked off all these blood vessels, creating these clots. Streptokinase, which is secreted by the bacteria, will actually dissolve those clots and allow the bacteria to spread through the body. And we actually use that bacterial enzyme. Streptokinase is actually used to treat clotting disorders such as myocardial infarct. So we've actually took advantage of that enzyme as a treatment for different clotting disorders that people have. DNase, anybody who's worked in the labs, worked with DNA, knows that when a bacteria lyse, if you don't, or mammalian cells lyse, if you don't actually shear the DNA, the liquid becomes very, very viscous. So DNA is very, very viscous. So if you have a bacterial infection, some of the bacteria is dying, other cells are dying. A lot of DNA is unlysed, unsheared DNA is being released, and you end up with kind of a thick jelly forming around the bacteria, and that's very hard for the bacteria to move through. And so it produces a DNase that degrades the DNA and reduces the viscosity. So all of these things working together are thought to be able to support pyogenes' ability to spread and to invade into different tissues. Like aureus, pyogenes makes exotoxins. They're called SPEs, or streptococcal pyrogenic exotoxins. Now, this is pyrogenic, not pyo, right? So these strains that make these are both pyogenic, forming pus, remember, and pyrogenic, meaning they cause fever. So if you produce these exotoxins, it's often associated with fever. All right. So SPEs, there's 3 that they can make. Pyogenes, different strains will make different ones. They can make A, if not A, they might make B, or they might make C, or they might make none of them. Now, A and C, shown in red, are superantigens. I'm not going to tell you how the superantigen works because you've already heard it so many times. But when they do produce, strains do produce them, that's associated with toxic streptococcal syndrome, which is not toxic shock syndrome. Okay, it's quite different. It actually looks similar, but it's much more serious, right? Sometimes they call it TSLS, which is toxic shock-like syndrome, right? But it's caused by a completely different molecule, but the mechanism's still the same. They function as superantigens. And SPEB, which is a completely different exotoxin, has a different function, and we'll talk about that as well. That causes something called scarlet fever, and we'll get to that in a few minutes. All right, let's talk about strep infections. So let's talk about disease now. You can have localized infections. Most common, you've probably all had it before, is pharyngitis or strep throat. So this is when it gets into your nasopharyngeal region. You get a sore throat, fever, nausea, malaise. Your adenoids might become swollen. If you look in the back of the throat, remember these are pus forming, so you'll see yellow pus. Another word for pus is exudate. Usually self-resolving, so the majority of cases you just get better, but there can be some serious complications associated with pharyngitis. Scarlet fever, we'll talk about it. Even more, which is not too serious, but even more severe or serious is acute rheumatic fever. We'll get to that in a minute. And acute glomerulonephritis, another complication. And so that's, and we'll talk about that in a minute. Skin infections as well. So that's infections of the throat. Now we'll talk about pyogenes also infect skin. There's that same diagram I showed you earlier. Remember with Staph aureus and folliculitis, and we talked about impetigo. Well, pyogenes can also infect the skin, and it actually causes even more types of skin infections than staph does. One thing it doesn't typically do is it doesn't typically cause folliculitis. So you don't normally get boils or infections of the hair follicles, but you do get other types of skin infections. Impetigo, we talked about it, so you know what it is already. It's highly infectious, remember, because it's on the surface of the skin. If somebody has impetigo, it could be staph, it could be strep. Chances are it's probably strep. Strep is more common, but you're going to have to do tests to distinguish between a staph and a strep infection to figure out which is it, because it could be either. Now, that's if you get an infection of the epidermis, remember. If you go down further, if you get the infection going deeper now, not into the follicle, but deeper into this dermal layer, okay, the infection can look quite different. You can get something called erysipelas, and erysipelas looks like this. All right, so here the infection was probably in the middle of this initially. So now what's happened is the bacteria has gone deep. This is a strain that goes deeper. For some reason, it likes the dermis better, and then it'll spread laterally, and it can spread quite far. You get this large inflamed region. It's still fairly close to the surface. So this is actually, this rash, it's hard to see in this is just a picture, but this rash is actually kind of lifted off the surface. So it's sort of a raised rash. So it's local, but it starts out as a local expression, local infection on the face. There it is on the face, on the legs. See it in children and the elderly. It spreads rapidly, so it ends up looking like this. Get fever, soft, often superficial tissues, so raised, red, inflamed areas. And this important here, defined edges. See how defined that edge is there? Or this here, you could take a marker and just mark along the edge of that rash. Okay, so it's something unusual about erysipelas. Now, let's say the bacteria goes even deeper. So instead of stopping here and replicating, let's say it gets down into this region, into your subcutaneous fat, and then decide it likes this area and starts spreading laterally and growing. And again, you're going to get inflammation. And now we're going to call this cellulitis, all right? Because it's in the fat tissue. And again, it's going to be rapidly spreading, but it looks a little different. See, we don't see that. There it is on the leg, but see, it's more diffuse. You couldn't really see where the rash starts and where it ends here. Now, we'll point out that these forms here are not particularly infectious. You can't infect somebody else. You can't scratch this and put somebody on somebody else's skin in the same way you can with impetigo, because the infection is deeper in the skin now. It's not out on the surface. So it's deeper, soft tissue, fever, headaches, chills. All of these, they're associated with fever. Remember, they're pyrogenic. Prognosis, good, timely treatment. Antibiotics, of course, will, you're going to treat a rash like that. You want to clear it up as quickly as possible. Complications, there's always complications. Bacteremia. So it can, the deeper it gets, the more likely it is to get into your vasculature and get into your blood. And if it gets into your blood, where is it going to go? It's going to go to your heart. They always seem to want to go to the heart, and you're going to have heart problems. But another major complication, even worse than bacteremia, and that you see just with pyogenes, is necrotizing fasciitis. And this is what can happen is if you get a strain that likes to go even deeper into this region here, into the fascia. All right. So necrotizing fasciitis is called hospital gangrene. That's a bad name for it because it's not gangrene, but it can look like gangrene. Gangrene is caused by different bacteria, but a better name for it is flesh-eating bacteria, because that's exactly what happens if it gets down into the fascia. Because up till now, all of these infections, the bacteria spread, but they're not really destroying that much tissue, right? They're just destroying enough to spread. If it gets into the fascia, these particular strains, they spread very rapidly, and now they're really, they're destroying a lot more of the surrounding tissue than you see with these other types of infections. And this only happens with very, very limited specific strains. So it's not all pyogenes can do this, just a couple of very rare strains. So how do you know it's happening when it happens? Well, okay, let's say, let's say you get a cut, right? Like a needle prick or some kind of cut on your skin. Now, you know how painful a pinprick or a cut or something like that on your skin can be. You have a good sense of that. You know that it's probably going to be annoying and painful for a couple of days, and then it'll get better. That same size little cut, if it's associated with necrotizing fasciitis, okay, it will be excruciatingly painful. So you'll have a tiny cut and you touch it and the pain will be excruciating. And that's because your tissue underneath it, deep underneath that little cut, is being eaten away and being dissolved by the bacteria. So it's that level of pain that tells you you've got a real problem. And it's very hot. You touch it, you'll feel all this heat. You'll get fever. Mental cloudiness. It can get into your blood. If it gets into your blood, that's crazy, because now it's going to spread through your body, and it's going to be doing it in different places in your body as it becomes lodged. And now, instead of having, like that 1 or 2% lethality we saw earlier with aureus and toxic shock syndrome, now we're seeing a 25 to 50% fatality rate. You do not want to get one of these infections. Diagnosis, clinical presentation, the pain, the pus will form. You'll be able to diagnose the bacteria. It's often associated with bacteremia, so you're going to be able to culture the bacteria from the blood. Treatment, you're going to flood the body. If you suspect this, the clinician is going to flood you with penicillin, and they're going to do a surgery. They're going to do what's called debridement, which is essentially carve out all the flesh around the area where the bacteria is thought to be. You really have to get at this quickly, be very aggressive. Often amputations are required to prevent this from spreading, these strains from spreading through the body. As I say, 50% lethality. Finally, pneumonia, showing up again. It's a rare, pyogenes can show pneumonia, but it's rare. And it's generally just associated, with bacteremia. The bacteria can make its way. If it gets into your blood, there are some strains that, this is a pneumonia that starts from a skin infection, right? So this is not something where a pneumonia where it's an infection of the nasopharyngeal region. There are some cases where some strains that if you get a skin infection, the bacteria will go into your blood, and then from your blood, it will go to your lungs, right? Directly, it'll be taken, it'll lodge in your lungs, and it can lead to pneumonia, but don't worry too much about that. That's, as I say, very, very rare with pyogenes. Toxigenic disease. Right, so we talked about the toxigenic disease associated with aureus. Now let's look at the toxigenic disease associated with pyogenes. Scarlet fever, okay, it's very rare. This is a complication of pharyngitis. It's the SPEB strain, remember? So it's not A and C. A and C are the superantigens. This is SPEB. So what will happen is you'll start with a sore throat, typical kind of strep throat, and then suddenly you'll have this body rash, your tongue will be bright red, and because the strain that's giving you the strep throat is making SPEB. So it's producing this toxin. This toxin spreads, you know, by your blood throughout your body. It finds its way into all the capillaries underlying your skin, and it damages those capillaries, and you end up with this this rash. And so it's a local infection with toxin that's being spread by your blood. It can be very uncomfortable, but most kids will recover from it. If you get it more than once, it would be very rare. Toxic streptococcal syndrome. This is a complication associated with erysipelas. So remember, erysipelas is a particular type of skin infection. Those strains that cause erysipelas, sometimes they also carry the SP, A, and C toxins. So again, it starts out as a local infection in your soft tissue, but you know, often if it's erysipelas, they can sometimes produce these toxins. They will get into your blood, and you can get shock, multi-organ failure, and a much higher fatality rate, 30%, than you see with toxic shock syndrome. So that 3% looks pretty wimpy compared to this. Post-infection sequela. So this is interesting. There's two different diseases associated with pyogenes infections, and these are diseases that you get after you recover from the infections. So, you know, you get the infections, you're feeling fine, you get better, and then, you know, a week later or 2 weeks later, you get another disease. And that disease is a consequence of that original pyogenes infection. And that's why we call it a post-infection sequela. Particularly important one is acute rheumatic fever. It's a sequela associated with strep throat. You see it in about 3% of cases. This is an inflammation of the heart, the joints, also can get into your central nervous system. And it's an example of something we call antigenic mimicry. Let me take you back to that M protein we talked earlier that pyogenes makes. Remember, pyogenes has this coiled, conserved region, all right? That's a little bit immunogenic. It's not as immunogenic as this terminal region, but you will produce a low level of antibodies, which will help you fight the infection, all right? So relatively low levels. Those antibodies generally don't cause you too much of a problem unless you get infected again. All right, so let's say you get infected again. So you have these memory B cells that are able to produce these antibodies. Well, if you get a second infection, let's say 6 months later, right, what you're going to do is you're going to have an amplification of your initial immune response that you had from the first infection. So you're going to produce the same antibodies, but now these antibodies in some cases are going to be produced at much higher levels. And what will happen is in a small number of cases, those antibodies that you produce of these coil domain get produced at much higher levels than normal. It's just a quirk of your immune response. The problem is this structure very closely resembles the structure of cardiac myosin. Right? And so those antibodies will actually cross-react with myosin. And what's thought to happen is that if you get a massive amplification on your second infection, they are thought to attack all the myosin or bind to the myosin. Whatever myosin in the body they can get at, these antibodies will bind to, and they will impair the function. And that's why you have a problem with your heart. There's a lot of myosin in your heart, a lot of myosin, obviously, in your central nervous system, on your nerves, so they can attack the central nervous system as well. All right. And so you get this, and it's a problem, and then you get better. It probably won't kill you, the acute rheumatic fever, but you still have the antibodies. And so if you get then infected again, if you have a third infection and a fourth and a fifth, every time you get infected now, you're going to get an acute rheumatic fever. And every infection is more serious than the last one. All right, so the fever is more serious. And eventually, if you don't treat it some way, it can kill you. So that's one sequela. We'll talk about how to treat it in a minute. Another post-infection sequela is called acute glomerulonephritis, or AGN. The good news is this only happens if you get it, and it's rare. It only happens once. Okay, this is a sequela of strep throat and sometimes impetigo. So you get a strep throat, you get impetigo, you get better. 1 to 2 weeks later, you may, say, in a limited number of cases, get an attack of AGN. And this occurs in just a subsite of the M serotype. So there's only certain strains that will cause this to happen. And these are M serotype. Remember the M protein, that with that variable region on the end? These are M serotypes that actually produce massive immune responses. Right? They're so immunogenic that you produce massive amount of antibodies, which is great, right? You can really clear that infection completely. But once you've cleared the infection, what you're left with is too much antibody in circulation. And that antibody needs to be removed. And what often happens is you have so much antibody in circulation now that it's going to be in complex with these antigens that, the bacterial antigens that it was clearing. There's so many antibodies that the antibodies will start to cross-link to one another. So you get these sort of lattice work of antibodies forming, and they're in circulation. Eventually, they'll make their way through the kidney, which is where they're supposed to go. And normally, you would always have these complexes. They should be removed by your kidneys, but there's too many antibodies. They form these lattice works. These lattice works become deposited now, okay, onto the renal basement of your membrane of your kidneys, and they cause your kidneys to clog up a little bit. And that can, it can be clinically problematic. You might need dialysis. Not many people die of it. You'll have kidney disease for a while. You will clear it up eventually. And the good news is there's no recurrence. You only have this once. And it only happens if you happen to get strep throat with one of these particular strains. So it's rare. Treatment and prophylaxis of strep infections. Treatment is generally thought to be immediate. Even if it's pharyngitis, you should probably treat it with penicillin. A lot of controversy about this. A lot of clinicians say, why are we giving penicillin for strep throat? Because, all this problem we have with antibiotic resistance. Well, the problem is acute rheumatic fever. And so a lot of clinicians want to treat strep throat very, very aggressively and prevent there from being a robust enough, clear the bacteria before you need to have this robust immunogenic response. So you can't make these, you don't make these antibodies, and there's a less of a chance of getting acute rheumatic fever. However, if you do happen to get acute rheumatic fever, that's a problem. You're going to actually have to go on chemoprophylaxis. So you will then, after your first bout with it, you're probably going to be a kid. It's a strep throat. So the first time you might be an 8-9-year-old kid. They're probably going to put you on antibiotics, chemoprophylactic antibiotics. And they may keep you on those antibiotics for 15, 20 years, switching them off so you don't become resistant to them. And the idea is to just, prevent you ever from getting another pyogenes infection. And generally you can start discontinuing them around the age of 20 or so. It seems like at around age 20, you become weaned off them, and it no longer seems to be an issue. All right, that's pyogenes. Now let's just, any questions before I move on to these other strains? We're only going to say relatively little about the rest of these strains, as I say, because most of them are going to show up in subsequent lectures. All right, good. So Streptococcus agalactiae, so remember this one. So this is distinguishable by several different tests. We can distinguish it from a pyogenes infection. For starters, a Lansfield test, it's actually group B. So this is a group B beta hemolytic, so we refer to it as GBS rather than gas. Skin, you'll find it on your skin, you'll find it in your nasopharyngeal passage, but you'll also find it at a fairly high level, in the genitourinary tract or the lower GI. It's particularly problematic in females, particularly pregnant females. So GI, it'll be found in the GI of the normal flora, about 25 to 40% of females. And what this can lead to is neonatal sepsis and meningitis. So unless you if you do something about it before childbirth, what can happen is during childbirth, the neonate can actually become infected. And this can lead, as I said, at a very high frequency to meningitis. And we're going to talk about this agalactiae again in the central nervous system lecture, and you'll hear a lot more about meningitis then. Now, not only the baby, but the mother can also be infected. Because remember, it's part of the normal microbiome. It's on you, normally can't get in, but this is an opportunistic infection. And so during childbirth, the bacteria will infect the mother, and that can lead to postpartum sepsis, which again is life-threatening. So GBS is a big problem. The diagnosis, remember, it's group B. Treatment is penicillin, but you're going to be if you're pregnant, you're going to be tested for this, and if you are positive, you're going to be given penicillin during labor. To really just to knock it out, and so it doesn't become a problem either for you or the newborn. So that's all I'm going to say about agalactiae. It's going to come up again in a later lecture. All right, here we are. So that leaves us physalis, bovis, pneumoniae, and mutans we haven't discussed, and we haven't really discussed how to distinguish between these four. So here's another couple of helpful tests that you need to be aware of. The first one is an escalin test called escalin hydrolysis. Escalin are carbohydrates, and there are some strains that can hydrolyze those carbohydrates and other strains that can't. And so this is what hydrolysis looks like. So this is a solid media with escalin in it. Bacteria is stabbed in it. If it's a negative, basically nothing happens. The bacteria just grows, but it stays the same color. If the bacteria produces, if the bacteria can hydrolyze the escalin, what you get is a color change. So it changes to black. So that's positive. So this is what physalis and bovis would look like. This is what pneumoniae and mutans. So that allows you to separate these two from these two. How do we distinguish between these two, physalis and bovis? There's one more test, and that's growth in sodium chloride. So 6.5% sodium chloride, that's a high level of salt. Most bacteria cannot grow in 6.5% sodium chloride, but physalis can. Physalis can, bovis cannot. So if you have a strain that's escalin positive and can grow in 6.5%, it's physalis. If it's escalin positive but cannot grow in 6.5% sodium chloride, it's bovis. Okay, see how we can use these different, it's not just one test that allows you to distinguish. It's a combination of results from different tests. All right, so let's talk about physalis and bovis. We'll start with bovis. So Streptococcus bovis actually was just recently named. I'm going to give you both names, bovis and galolyticus. It was very recently renamed galolyticus. So if you are reading textbooks, you'll hear it bovis. So it would have to be a pretty recent textbook to call it galolyticus, but just be aware that this strain is, there has been a name change done. I'm holding you responsible for both names, although on an exam, I would use bovis. I don't think I wouldn't use galolyticus on an exam, but I would use bovis. What do we know? We know about it. It's group D. It can be alpha hemolytic or no hemolysis. So it's a little wimpy with the hemolysis. Part of your normal flora. We find it in the gastrointestinal tract. When you get infections, it can be associated with bacteremia. So infections often lead to it getting into your blood. And when it gets into your blood, we see heart disease, so endocarditis. Interestingly, it's very commonly associated with malignancies or pre-malignant lesions in the colon. So presumably, if you have lesions in your colon, you're creating opportunities for the bacteria to infect. And, the colon is one area of the body where this bacteria would be found. And so, when it enters, through that lesion, as I say, it can spread to the heart and you can get disease. So endocarditis associated with a malignancy is a fairly common presentation of these types of infection. Enterococcus, again, so this is the other one, group D. This is Enterococcus faecalis, but actually there's two I want you to think about, faecalis and faecium. Now, faecalis is much more common. So about 90% of enterococcal infections would be faecalis. The other 10%, these are infections causing disease. The other 10% would be faecium. But even though faecium is much less common, clinically, it's more problematic. And I'll explain that in a second. So again, they're part of normal flora. They can infect the GI tract, the genitourinary tract. Always remember, they can also be on your skin. They can also be in your throat. Endocarditis, so they can get into your blood. About 10% of cases of endocarditis are associated with faecalis infections. So it is a major cause of endocarditis. A lot of ways you can get inflammation of your heart. 10% of the cases of heart inflammation are caused by infections with this one strain of bacteria, faecalis. It also causes urinary tract infections, about 10%. Meningitis, so that's why I'm not going to say a lot about it, because it's probably going to show up in the central nervous system lecture. You'll find it in wounds, you'll find it in abdominal abscesses, so this thing is showing up in a lot of different cases. The reason faecium is more clinically important than faecalis is because of drug resistance. Remember remember I was telling you that I was telling you earlier about vancomycin resistance finally starting to make its way into bacterial population. Guess where vancomycin resistance came from? Faecium. So it's, a lot of different, high number of strains of faecium, are actually resistant to vancomycin, all right, because they carry a vancomycin resistant gene. And they're able to pass that to other species. So they have transmitted that resistance to faecalis. So now we're starting to see it show up more and more in faecalis. So Enterococcus overall is becoming quite a source of vancomycin resistance in the world. So as I say, it all started here with this species. And this just shows you the problem with back in 1989, this is looking at resistance to vancomycin. This is enterococcal resistance to vancomycin. In 1989, there was no such thing as vancomycin resistance. And then it started very, very quickly. This is, up to 12% of cases in ICU units, up to, 8% of cases in non-ICU units. This is a 5-year period. Right now, we've been able to level this off. We've been able to control the spread of this resistance more and more. But I say it just came from nowhere in the faecium species, and then it spread to faecalis. And fortunately, it's still a fairly low number of faecalis strains contain it. But and as long as we're careful in our use of these antibiotics, we can probably keep this under control. But boy, you don't want to lose your vancomycin. So treatment, you can still treat them with penicillin. So that's, even though they're vancomycin resistant, you can treat them with the penicillin. If they are penicillin resistant, and they're not vancomycin resistant, then you can treat infections with vancomycin. So as I say, not every strain is vancomycin resistant, so you can still use it. But penicillin is preferred, and you generally add an aminoglycoside. These are enterococcal infections are usually treated with 2 different antibiotics. All right, so that's Bovis and Physalis. We're almost there. We're down to our last two strains, pneumoniae and mutans. We still need a test to distinguish between those two. And we have one really good test that allows us, and that's an Optoshin sensitivity test. It's a great test. The test is like an antibiotic test, except Optoshin is not an antibiotic. It's actually a chemical. And so what you do is you take a plate, and you put a little disc on that plate, which is soaked with Optoshin. So the Optoshin just kind of, leaches out of the little disc. And then you can streak the bacteria on there. If you streak mutans on there, Streptococcus mutans is highly resistant. So it doesn't care whether there's Optoshin there or not. It'll just keep growing. It won't grow on the disc, of course. Nothing can grow on a disc. But it'll grow up to and all around the disc. Pneumoniae, you do the same thing, and you'll get this zone around it, where it can't, where that Optoshin is secreted out, the bacteria can't go. So nice, easy test. That's what a picture of that's what it really looks like. Okay, so this is sensitive. So this is pneumoniae that's been streaked. Remember, pneumoniae is alpha hemolytic. So see how these mucousy green bacteria growing here. And this is a blood agar plate that's got this little Optoshin disc, and here we see this zone of clearing. All right, so we'll begin by looking at mutans. As I say, these are alpha hemolytic. I just showed you an example of pneumoniae and mutans. They're both alpha hemolytic, reliably alpha hemolytic. Part of your normal flora. Often you'll find it in the mouth. 30 to 60% of us have it in our mouths, but it's not nasopharyngeal. We'll find it on our tongue and in our gums, and it's going to give us, we're not careful, don't clean our teeth properly, it can lead to cavities, and it can get into your blood. If it gets into your blood, it can lead to endocarditis. But it's not as problematic as some of the other strains in terms of the type of inflammation in the heart. It's not as serious as endocarditis unless you have an underlying heart problem. So that becomes a bigger issue. If you have bad teeth, lots of cavities, and you have an underlying heart problem as well, this becomes a real problem. So, how do you get it? You get it from a dental treatment. It could be just a cleaning. It can lead to an infection. But again, if you don't have the heart problem, it's probably not such a big deal. If you're too vigorous a brusher, that can lead to transient bacteremia, and then that can lead to your endocarditis. Treatment, penicillin. Whenever I put something in brackets here, I usually do it like parentheses. I usually put it next to penicillin because so many people are penicillin resistant. This is what's in parentheses is what you use if you're penicillin resistant. So treatment is typically penicillin plus gentamicin. If you're penicillin resistant, you would use, or sorry, not resistant. If you have an allergy to penicillin, which many people have, of course, then you can't use the penicillin, then you would use the vancomycin plus gentamicin. All right, so if it's a parentheses, that's what you use if you have an allergy to penicillin. Prophylaxis, antibiotics. That's why if anybody's had tooth extractions and such, crowns and things like that, often you're after the treatment, you'll be given antibiotics. Your dentist will give you antibiotics, and that's to prevent mutans infections. Last strain we're going to consider today, and again, we're not going to spend as much time as we should. It's an extremely important infection, Streptococcus pneumoniae. 50% of the cases of pneumonia in the United States every year caused by this bacteria. But you're going to hear all about it again in a couple of weeks. When you get I'm not sure who's doing the lecture. I think it might be Dr. Kabak coming back to lecture on respiratory infection. So he'll talk about Streptococcus pneumoniae. That's not to say you're still responsible for it on this exam next week. You're responsible for everything I tell you, but you will learn more about it later, as I say. Alpha hemolytic, remember diplococci, that's actually very useful. This is heart tissue, and you can see, this is lung tissue. The patient has pneumonia, and somebody, we're looking at lung tissue, you can see these diplococci. So these diplococci are actually, if you see something like that in your lung, you have a Streptococcus pneumoniae infection. Remember, they're uptoshin sensitive. That's how we, that's really the definitive test. Part of your normal flora, not surprisingly, we see a lot of it in the nasopharynx. That's how it gets down into your lungs. So depending what population you're looking at, anywhere from 5 to 70% of the population may have this as part of their in the back of their throat. This is the only bacteria we're talking about today that makes a capsule. So it makes one of these thick phagocytic capsules, which makes it a real problem to treat. These bacteria that have capsules, they don't get opsonized particularly well, which means it's hard to clear them using your white blood cells. We have to clear them through other mechanisms. There are actually even more problematic is that there are actually 85 different strains of Streptococcus pneumoniae, and every strain has a different capsule. So, creating vaccines has been a real challenge. So that's the bad news. The good news is, of those 85, only 23 cause disease. The rest don't really cause disease, so we don't worry about them. But still, 23 is a big number, all right? And you have to, if you want to get a vaccine, we do have vaccines, but that was the challenge with developing the vaccines. Those 23 strains are responsible for about 85% of the disease associated with pneumonia infections. So you get lobar pneumonia. There's actually two types of pneumonia you can get, lobar and bronchial. Bronchial is when the bacteria gets into your bronchi, which are the two large branches coming up the bronchus. And then if you get into the alveoli, out into the lobes of the lungs, what we call the lobes, it's called lobar pneumonia. And that's where the bacteria gets, out into the lobes. It starts with an upper respiratory tract infection, obviously, and in some cases, these strains can get down into your lungs. Anybody who's ever had pneumonia, really what's characteristic about it is this sort of shaking chill. You're going to have a high fever, you'll feel kind of crappy, but that's pretty non-specific, feeling crappy with a high fever. A lot of things can cause that. But then suddenly you'll start shaking and you feel freezing cold, and it's called a shaking chill. That's pneumonia when you start getting things like that. A lot of chest pain. You'll have what's called a productive cough. So there's dry coughs and productive cough. A productive cough means you're coughing up sputum. Remember, everything we talked about today is pyogenic, so they produce pus. Wherever the infection is, even if it's in the lungs, pus is being produced. So you'll cough up that pus, and it's kind of a rusty color. We call it sputum. About 500,000 cases per year in the US, about 40,000 deaths. So that's a serious health issue. That's all I'm going to say about it. We'll talk about the vaccines in a second in the last slide, I think. But that's all I'm going to say about the pneumonia, because you're going to hear a lot more about it from Dr. Kabak. Otitis media, middle ear infections also. So, you get it in your throat, maybe it goes to your lungs, but sometimes it doesn't go to your lungs, it goes to your ears. It goes to the tympanic membrane in your ears and infects those membranes, and you end up with a middle ear infection. In fact, 50% of middle ear infections in the United States every year are caused by these pneumococcal infections. So it's something that people don't realize. That accounts for 10 to the 7th visits to the pediatrician every year, which is incredible healthcare cost in the United States. So that's why there's so much effort put into developing vaccines. And generally, these are kids with very poor ear drainage. And, one of my two kids had issues with middle ear infection. So it's very common. And meningitis, again, it's going to come up again in the central nervous system lecture, so I won't say anything more about that. Epidemiology, how is it spread? It's spread more typically, you won't find this one on doorknobs and, from skin infection. More typically, it's going to be spread from individual to individual by aerosol. So you might cough, just even breathing out. If you have it in your throat, you breathe it, somebody else breathes that in. That's how both, non-disease causing variants as well as the disease causing variants can be spread. People at particular risk are people who have issues with their spleen. And why is that? The reason is because of these capsules. Because they have these capsules, they can't be properly opsonized. So they're not efficiently cleared, okay, by your white blood cells. But that, your spleen can clear them. One of the functions of the spleen is if you get these capsulated capsulated bacteria, as they pass through your spleen, they will be recognized in the spleen and they will be removed and destroyed in the spleen. And that works great if you have a nice healthy spleen, but some people don't. So patients, for example, with sickle cell anemia are particularly susceptible to these infections. They can't clear them, and it will actually kill people with sickle cell anemia. And the reason for that is because these patients have these sickle cells, and the spleen is so busy trying to remove these abnormal red blood cells. They're functionally asplenic. The spleen just doesn't have the ability or the resources necessary to deal with both sickle cells and encapsulated bacteria like that. So those individuals are at high risk. Alcoholics tend to have messed up spleens, so that's a problem. Young people, the elderly also don't have fully functional spleens, and that creates issues. Treatment, immediate, penicillin. All right, so penicillin, if you have an allergy to penicillin, there are other possibilities, vancomycin, for example. Where are we now? I think this is the last slide. Prevention. There are, the good news is that there are actually vaccines, and there's 3 of them. The first one that was released was a polyvalent vaccine called Pneumovax. It's a polysaccharide. This will actually target the 23. Remember I told you there's 23 virulent strains. It targets all 23. So they have polysaccharide capsules. It targets all 23. And this is a very useful vaccine, and it's very useful for people over the age of 65. So this is the vaccine. It's called Pneumovax. We use it people over the age of 65. Now in the year 2000, Prevnar was marketed. This is actually a conjugate vaccine. The problem with Pneumovax is it's polysaccharide, and polysaccharides are sugars, and sugars are not as immunogenic as proteins. Proteins are great at eliciting an immune response, sugars less. So this is a pretty good vaccine. It does the job for the elderly and giving them protection, but it didn't work so well in small children, and it, as the sort of the standard. So there was a need for a better one. And so Prevnar that came out in 2000, what they did is they took the capsules of the 7 most virulent strains, conjugated them to a carrier protein so they could generate a better, a more potent immune response. Not to, the immune response isn't to the protein, it's still to the carbohydrates, but the fact that there was a piece of protein attached meant that it generated a more robust immune response. So it was much more immunogenic, and that's the one that's used. That's the standard one that you give children under the age of 2. And then there's a new one that's come out in 2010, Prevnar 13. And instead of targeting the 7 more virulent, it actually targets 13 most virulent strains. There might even be another Prevnar now, but Prevnar 13. And again, so the idea is to get as many of those 23 different strains covered as possible. And this, I think, is my last slide. This is just just to remind you, it would be probably awfully useful for you two guys or everybody as you studying for the exam to have this kind of table and to learn this kind of table. It just summarizes all the different tests that we talked about. And you can see that each strain has different combinations of, whether they're positive or negative on these different tests. And it's never just one test. It's always, the results, something is Lansfield group A, beta hemolytic, bacitracin sensitive. That's a pyogenes, right? a beta, Lancefield group beta hemolytic, backcitration resistance. Okay, you see that combination, you say, this has to be a galactii, right? So it's not learning one test, you have to learn the combinations of test results that will lead you to these definitive types of diagnosis. And, you'll have to do some of this next week on the exam, but as we go forward, we're going to talk now, we're finished with the basic bacteriology. Particularly the next exam, is going to be a lot of bacteria, a lot of different strains. It's become more and more important to you that you have these kinds of tables, build these kinds of tables to allow, to have all the information in front of you that allows you to distinguish between different possibilities. Because, you'll get a case where it could be one of a couple of different things. And then it'll say, okay, here's the symptomology. Now here's the test results. Now tell me what it is. And, so you have to know, what diseases are caused by this different strains. And if the same disease is caused by a couple of different strains, what tests results would allow you to figure out which one it is. All right. And I think that's it. All right. And let me see where we are. Well, so again, I apologize. I think I spent a little too long talking about the exam today, so I ran over a little bit. But I am happy to. I'm just looking at the. Okay. So, any questions? If there are any questions, please feel free to unmute. Any questions about the stuff we talked about today, or anything about the exam? All right. Good. I mean, the first thing that's going to happen now is what will happen is in the next day or two, you're going to get probably going to get an email. I'm going to cancel next week's session. And so because I don't want anybody by accident using that link next week and thinking they're going to go to that link and take the exam. All right. So that if you see that link canceled, that's what I'm doing. All right. So I'm just knocking that out so that link can't be used. And then, again, probably within the next couple of days, you're going to get an invitation. And don't panic. If by Monday morning you have not received a new invitation, a link, okay, a Zoom link for the exam, then you can panic. You reach out to me and I'll make sure you get a link, right? And I'll be looking. So. But, these different proctors that I'm using, different faculty members, some, I'll send them the lists, people they need to schedule in the next couple of days. Some will just do it right away. Some may wait till Sunday night before they do it because they know, the exam isn't until Tuesday. So as I say, don't get too panicky. And if you haven't got an invitation by Monday morning, just reach out to me and I'll figure out what's going on. All right. And so that's that. In terms of posting the exam, it's not finished writing yet. So I'll post it as soon as it's finished. I'll probably finish the exam. Probably tomorrow. I'm still waiting for some questions from Dr. Humayun. So, and and he's supposed to get them to me today. So once I've got those in and a nice close edit, I'm waiting for his choices anyway. And then I'll try to post the exam before the weekend. And again, I'll post the exam probably Friday afternoon. And then right away, I'll send out an email saying I posted the exam. And if you did not get a notification that the exam is posted, let me know immediately or let the graduate school know immediately. And so fortunately, the exam is on Tuesday, not on Monday. So that gives us, even if we can't fix things on the weekend, we'll certainly be able to fix any problems on Monday. Okay, so that's sort of the sequence of event. Remember, content-driven, study hard. The more you know, the more you learn, the better you will do it. There's no trick to this. There's no. It's as I say, just content-driven. There's no. It's not like you can learn. It's not like teaching yourself to do these kinds of questions or anything like that. They're not that. Even the clinical vignettes, they're not that complicated. They're just pretty straightforward, just say different presentation of a very similar questions. All right.
Thanks, Professor. Have a good rest of your week.
You too.